Good morning, everyone. At the outset, let me thank Dr. GVK sir and Chairperson sir, as well as the entire team of 3DCon. It's really an honor and always my pleasure to be here, especially for the Andhra delicacies. So, without much ado, again a very special topic that Dr. GVK sir always he makes it a point to bring out all the practical issues and practical topics for discussion. So again, diabetes management in acute illness. This is a special condition because and has to be highly personalized and customized based on the situation and based on the general condition of the patient as well. So as we all know, type 1 as well as type 2 diabetes are both associated with a high risk of infection, higher rates of hospitalization, ICU stays, and death related to these infections as well. The strongest association, as per some studies, have been with bone and joint infections, sepsis, and cellulitis. A large Canadian study found that when they looked at 1 million individuals, in those with diabetes, at least 50% of them reported an infection in the first 3 months itself of the study, compared to 38% in those without diabetes. And again, strong predilection towards upper respiratory tract infections, cystitis, and pneumonia with diabetes. Korean studies have also shown us that there's a greater risk of infection related ICU admissions as well, and death when hospitalized with infections of skin or soft tissue, central nervous system infection, bone and joints. I think a lot of these have come to the fore after the COVID pandemic also. We started noticing and looking at the numbers of hospitalization, ICU stay, length of stay, etc. etc. Again, even all the comorbidities with diabetes also make it difficult to actually look at the epidemiology, but nevertheless. And in sepsis, again, the epidemiology, the studies are not so many, and that needs to be, we need to have a better understanding of diabetes and sepsis in terms of numbers. So again, just a review of some of the commonest infections that we encounter with diabetes. Pneumonia and tuberculosis amongst the respiratory illnesses. Pneumonia has very high rates of hospitalization and mortality in those with diabetes as compared to those without, and they may not have the classical symptoms of pyogenic pneumonia as those without diabetes. Of course, that needs intensive and aggressive treatment. Tuberculosis on one hand has very high risk of contracting with risk corresponding with the level of glycemic control. The worse the control, the higher the chances of tuberculosis activation and higher risk of treatment failure as well. Again, isoniazid needs to be given with pyridoxine to avoid the vitamin B12 deficiency because that can aggravate neuropathy in those with diabetes. Rifampicin again may cause cytochrome P440 induction, and that also impacts the clearance of the anti-diabetic agents. So again, the doses have to be monitored and adjusted accordingly. In terms of skin and soft tissue infections, we know cellulitis, abscess, necrotizing fasciitis are very common. Sternal wound infection, in fact, that is pathognomic, that if person has diabetes may definitely have this infection. Fournier's gangrene also has been noted along with SGLT2 inhibitor use, but a strong causative association has not been noted. Moving on, again hepatitis and empylomatous cholecystitis, all these have to be seen in terms of the effect of the liver function, because if that is impacted, then again the use of oral anti-diabetic agents may be impacted. Urinary tract infections, also very high rate of infection and failure and relapse with treatment as well. Most common organisms are E. coli and Enterobacteriaceae. Urine culture is strongly recommended for those with diabetes, and not to treat indiscriminately with antibiotics without knowing which organism and which antibiotic it is sensitive to. There is higher risk of progression to pyelonephritis, which needs to be kept in mind. Again, you have many others, and including the fungal infections as well. So the entire objective is to recognize the pathophysiology of stress hyperglycemia, which may be associated with these infections, identify the glycemic targets in acute illness, guide insulin as well as non-insulin therapy, and prevent and manage acute complications like DKA, HHS, and hypoglycemia, which was very nicely alluded by the previous speaker as well. Illness is most likely to have an impact on the glycemia are even as simple as common cold or flu, including COVID-19, a sore throat, urinary tract infections, bronchitis, chest infections, stomach upset, diarrhea, and skin infections such as abscesses, etc. Starting a course of cortisol or increasing the already ongoing cortisol may also have a significant impact on blood sugars, and that needs to be kept in mind. Why does acute illness matter in diabetes? Because hyperglycemia is associated with worse outcomes, whether it is infection, surgery, or even wound healing. And it definitely increases mortality besides the impacting the healing, increasing the hospitalization, increasing ICU stay, or increasing the length of hospitalization as well. Stress hyperglycemia can unmask undiagnosed diabetes, which is associated with increase in the levels of cortisol, catecholamines, glucagon, and cytokines, and reduction in insulin sensitivity and insulin secretion as well. It may be transient but harmful nevertheless and requires proactive management. Again, this may be triggered by infection states, even cardiovascular ischemic events, gastroenteritis, dehydration, etc. And even a minor illness with diabetes may trigger persistent hyperglycemia and other life-threatening complications. Hence, education is a must. People living with diabetes, their caregivers, and also parents of those living with type 1 diabetes need to work with the healthcare providers and their team to come up with a sick day plan, which is absolutely mandatory whether you have type 2 diabetes or even type 1 diabetes. The target blood sugar goals during an illness should be known to the patient. How to adjust the medication should be discussed. When to contact the healthcare team is also equally important, and how to check their blood sugar and ketone, how often to check them is also very, very important. When ill, probably the insulin requirements may go up, even if the patients are unable to eat or drink normally, and this should be emphasized to the patient. So now this trigger is also important. When should the patient contact the healthcare provider in case of acute illness? If they are not sure what to do, if they are vomiting repeatedly and have not been able to hold down any food or drink for at least more than 6 hours, due to the risk of severe dehydration, they must contact their healthcare providers. If their blood glucose stays high for more than 24 hours, or if they develop symptoms which could be indicative of impending diabetic ketoacidosis. Again, the symptoms of ketoacidosis and the blood levels, blood sugar levels, etc. I have described in the table. But seeking urgent help in case of vomiting, rapid breathing with fruity smelling breath, abdominal pain, etc., definitely contact the doctor, and that requires admission as well. Now, in terms of general guidelines on managing diabetes during illness, the following have to be followed even if there is normoglycemia. Take the diabetes medications as usual, and insulin treatment should never be stopped. Test blood glucose every 4 hours and keep track of the records. Drink that extra fluid and try to eat as normally as possible. Fluid meaning at least half glass to 2/3 of a glass of fluid every half an hour to prevent dehydration, and try to avoid the sugary beverages. But that may have to be taken even if there is less than 50 grams of carbohydrate intake through food. The amount of sugar beverages have nevertheless to be carefully controlled to prevent blood sugar levels from rising too high and too fast. A good idea is to weigh the patient as well. So, and losing weight even after eating is not a very good sign, and the doctor should be contacted. Check the temperature every morning and evening, and a fever may definitely indicate infection. In terms of ICU patients, again, the various bodies across the world have recommended a target of 140 to 180 milligrams per DL, and non-ICU patients pre-meal target can be less than 140, and a random less than 180 milligrams per DL is associated with the best outcomes. To avoid blood sugars going less than 110 milligrams per DL due to the risk of hypoglycemia, and this is something that needs to be kept in mind. So the diabetes perspective, first of all, one needs to understand whether it's type 1 or type 2 diabetes or undiagnosed and is being unmasked at the time of the illness. The nutritional status, whether the patient is eating normally or is nil by mouth or is on tube feeds. The severity of illness needs to be assessed, and the current medications ongoing also need to be kept in mind. For those with type 1 diabetes, I am not going into details, but insulin should never be stopped. In fact, the dose may need to be increased, and additional fast-acting insulin boluses need to be given to bring the blood glucose down. The blood glucose levels during an acute illness should be checked every 4 hours. For example, if they are between 180 and 270 milligrams per DL, they should be checked every 2 to 4 hours, and anything above that definitely more every 2 hours for sure. In that case, they should also check for clinical signs suggestive of ketoacidosis and look for blood or urine ketones as possible by the patient at home. Ideally, we need the blood sugar levels between 110 and 180 milligrams per DL. In those with type 2 diabetes, they also need to check for symptoms of high hyperglycemia, like a thirsty or a dry mouth, passing large amounts of urine, and tiredness or fatigue or even acute weight loss. Those on tablets, well, metformin, because of lactic acidosis in a case of severe dehydration or severe infection, may need to be withheld for a while, and an alternative may need to be started until metformin can be reinstated. SMBG should be continued to detect any hypoglycemia or routinely to track the blood glucose levels, and there may not be an additional need for frequent monitoring, but keeping an eye on the sugars is always a good idea. However, during an illness, definitely blood glucose levels rise, and SMBG will guide the treatment, and hence we know the target is between 110 and 180 milligrams per DL, but there is a need to check blood sugars in those cases at least twice a day. In terms of SGLT2 inhibitors, stop during acute illness, surgery, or in the fasting state because of the rate or potential of euglycemic diabetic ketoacidosis, which is very high in these individuals. Only resume when the oral and intake of fluids is good and the patient is stable. In terms of those on insulin, the basal insulin should never be stopped. The dosage can be reduced. The aim is again to maintain blood glucose between 110 and 180 milligrams per DL. Check the blood glucose every 4 to 6 hours. Stay hydrated, eat as possible. And if the blood glucose levels stay above 180 milligrams, insulin doses need to be increased. Additional testing may be undertaken every 4 hours or even more if there is hyperglycemia, especially above 250 or 270 milligrams per DL, and ketones should be checked if there is persistent hyperglycemia. And you know all the signs when to call the doctor. I already went through that earlier. Inpatient glycemic targets, in the ICU, IV insulin infusion is preferred, and the non-ICU patients, basal bolus is preferred. Please avoid the sliding scale monotherapy. 2 minutes more, please. Adjusting the dose based on the feeding status is what is recommended. In terms of steroid-induced hyperglycemia, based on the steroid use, we can use either NPH or premixed insulins, or stick to basal bolus or even basal plus therapy as appropriate. In terms of enteral or parenteral feeding, we would look at basal bolus with short-acting analogs that would work very well. In terms of TPN, again add insulin to the TPN itself or basal bolus regimen and monitor the glucose every 4 to 6 hours. Special situations, again the use of oral drugs is very tricky and should be avoided in case of renal failure or sepsis and cardiac patients, strictly to avoid hypoglycemia at any point. Discharge planning, of course, you need to look at the post-acute illness status, restart the oral agents, educate the patient again on the sick day rules and glucose monitoring, and ask the patient to follow up on the OPD basis. So the key takeaways are acute illness alters glucose metabolism dramatically, and insulin is the cornerstone in hospitalized settings. One has to prevent DKA, HHS and hypoglycemia through vigilance, and individualization is recommended based on the illness, nutrition and baseline control. In terms of COVID-19 infections, there's a lovely chart, outpatient care, how we prevent it completely with better hygiene and optimizing the blood glucose control. This is actually, I'm just quoting COVID-19, but this is true for every other infection in cases of diabetes. Inpatient or intensive care unit, again we know that besides optimizing the insulin therapy, we need to screen for associate electrolytes, blood ketones, the pH and also the presence of beta hydroxybutyrate. And IV insulin should be liberally considered in case of the ICU setting. And simultaneously, antihypertensives and dyslipidemic drugs also should be continued because so that the comorbidities are well controlled as well. The insulin, again, the signs and symptoms of severe illness, and so that there is no delay in seeking care and hospitalization, they should be well taught to the patients and their caregivers. Other metabolic conditions have to be well controlled. Metformin is best avoided in these settings, and SGLT2 inhibitors as well. There is no evidence that DPP4 inhibitors should be discontinued, so they can be well continued. The risk of hypoglycemia is always present, and hence there has to be discretion in using the sulfonylureas and meglitinides. Again, there's a beautiful table to describe all of this, and that can be referred to. These are the references I've used, and thank you again for a very patient hearing.